Right, hi. I look after a couple of thousand adults with several hundred different inherited metabolic diseases at UCLH. So I wasn't happy with uncertainty. I would have left my job many years ago. But I do deal with the late outcomes of newborn screening. And if we actually look at the paradigmatic newborn screening disease, that's phenylketonuria. So it's an enzyme deficiency, and deficiency of phenylalanine hydroxylase leads to a buildup of phenylalanine. And phenylalanine is toxic to the brain. So the phenotype of PKU is of severe learning disability. There's a severe phenotype and there's a treatment. The treatment for PKU is not a gene therapy at the moment. It's not a drug, it's a diet. So these babies are identified on newborn screening, and we introduce a low protein diet, because by giving a low protein diet, low in phenylalanine, we can reduce the amount of phenylalanine in the blood. We give back protein substitute, which doesn't contain phenylalanine, so they don't become malnourished. And by doing that, we can bring down phenylalanine levels and we can get normal neurodevelopment. And nowadays, babies born with PKU and treated early should have normal outcomes psychosocially and educationally. The paradigm for screening is a newborn blood spot. So we take a newborn blood spot and we measure the phenylalanine level. But when we look at newborn blood spots, we'll see a whole range of different phenylalanine levels, ranging from the normal range, which is about 0 to 150, and going right up to over 2,000. But that's because not all mutations, as we've alluded to, are the same. They're not all null mutations that knock out enzyme activity altogether and would give you classical PKU. They can leave you with different amounts of residual enzyme activity. And in fact, for most enzymes in the body which aren't rate limiting, if you've got 30–40% of your enzyme activity left, and certainly 50% if you're a heterozygote, you don't get clinical disease at all. So we're actually looking at mutations right up in this end here. And in PKU, we have classical PKU, mild PKU, and hyperphenylalaninemia, which is really levels that don't necessarily need treatment. We've been doing it for 55 years now, so we're pretty good at what we're supposed to do. And the paradigm compared to the CF paradigm is really very simple. You take the blood spot, you measure phenylalanine once, you decide whether it's above a certain threshold, 200, you repeat it again to make sure. And then, because not every disease that gives you a high phenylalanine is PKU, you also measure the tyrosine levels. They should be low in PKU. So if your tyrosine is low and your phenylalanine is high, you've got PKU. Otherwise, you get tested for something else. So the calling of this baby is solely based really on the results of the blood test, and then they're referred in and started on a low protein diet. And we have lots and lots of guidelines, so we know exactly what to do with these children. In PKU, treated children up to the age of 12, we're targeting phenylalanine levels of 100 to 360 micromoles per litre in the blood. So we adjust their diet to achieve these levels. And as I say, the outcomes of this have been extremely good. There's a variability of different peoples with PKU, but there really isn't very much uncertainty. We know exactly what we're supposed to do. But what happens when you can't actually direct that screening, that you can't directly link the result of that screening test to your clinical outcome? What do you end up with then? So I'm going to talk about two other inherited metabolic diseases, which we don't currently screen for in this country, but they are screened for in other countries, and both of them are on the generation study list of conditions. So the first one is a lysosomal storage disorder called Pompe disease, or glycogen storage disease type 2. It's also an enzyme deficiency. It's due to deficiency of this enzyme, the acid alpha-glucosidase, which breaks down glycogen in the lysosome of cells into the constituent glucose molecules. And this disease expresses itself in muscle, and in muscle cells, you will get buildup of glycogen within the muscle cells that leads to muscle dysfunction, eventually muscle cell damage and fibrosis and loss of your muscle as it progresses over time. We also have a spectrum of disease severity, as we did with PKU, that relates certainly mostly to the residual enzyme activity in the cell. And so the severe form of this disease, where you really have essentially no enzyme activity at all, presents very early on in life. And the muscle that's primarily affected is the heart. So these babies present with a massive cardiomegaly, so that heart is actually expanded. It's a hypertrophic cardiomegaly. They also have skeletal muscle weakness and respiratory failure. They present consistently within the first couple of years of life. And the natural history is that these babies will be dead within a year. However, once you have a bit more enzyme activity, probably more than about 5%, you see a completely different clinical presentation. And that's because cardiac muscle is spared once you have that type of activity. And instead, what you see is a disease that's of later onset, either juvenile or indeed adult, and leads to a proximal myopathy. So people noticing problems with their gait to start off with their breathing muscles sometimes, and ending up in a poor state, wheelchair bound, requiring ventilation at night. But this gentleman would have presented sometime in his 20s or 30s. progress very slowly and has exactly the same disease molecularly, maybe not at the level of mutation as this child has. So two very different phenotypes for the same disease. The disease is treatable. We can give these patients enzyme replacement therapy. So we can make the enzyme in a bioreactor, purify it, and inject it back into the patient. And in babies, this is life-saving. So providing you get to these babies early on in life, and the earlier the better, and you start them on enzyme replacement therapy, you can see that mortality is really much better. And this is from very early days. We've got better at this now. But in late onset disease, it's a very different thing. The effects on skeletal muscle, and this is probably true of these babies as they get older as well, are much less obvious than they are on cardiac muscle. And the best we can say for this is that it probably delays the onset, delays the progression of the disease. It doesn't stop it altogether. It may make the clinical course somewhat longer. And these patients don't get started on treatment until they actually show clinical symptoms. So we want to do newborn screening in order to identify those infantile onset patients so we can start them on treatment straight away. And we do that by measuring first the actual enzyme activity in a blood spot. You can do that, but you're using an artificial substrate. It's on a blood spot, not in cells. So the results aren't always entirely reliable, and they back that up with the second step, which is actually to sequence the GAA gene. So you're looking for babies with low enzyme activity and with abnormalities in the gene. And now you've got a much more complicated looking screening protocol where if you've got low GAA activity and you've got GAA variants, they can classify the variants, they can decide what you are. Basically, the screening test here involves physical examination. So you have to call these babies, you have to get them seen by a clinician who decides whether they have a normal heart, not a normal heart. So if you've got cardiomyopathy, then we've identified you as having infantile onset Pompe disease and you start an enzyme replacement therapy. But many more patients will have a normal cardiac elevation. They'll be low activity, they'll have genetic variants, they may well have pathogenic variants, but they'll be entirely well at the time you see them. And they've got late onset Pompe disease. So what do we do with those patients? So this is the paradigm used by one of the American centers. So recommended follow-up and treatment algorithm. If they become symptomatic, then you can start them on enzyme replacement therapy, but a lot of them will be asymptomatic, and they're being evaluated in infancy every 3 months during the first year post-diagnosis. If they're still symptom-free at 12 months, it's every 3 to 12 months. And this evaluation will go on and on until such a time as they actually develop some symptoms that you can treat. So the price you're paying for saving the lives of babies with IOPD is a lot of patients with LOPD, where you're completely uncertain about what's going to happen to them. And many of them may not develop clinically significant disease for many decades. The average age of patients we're seeing presenting, they're getting symptoms in their 40s, 50s, even 60s. And some of them indeed may not develop disease at all in the future. So the second condition I'm going to talk about is X-linked adrenal leukodystrophy. This one isn't an enzyme defect. It's mutations in a gene that encodes a transporter that transports very long-chain fatty acids into the peroxisome of the cell where they're oxidized. And if the transporter isn't working properly, you get an accumulation of very long-chain fatty acids in the blood and in different cells in the body. And this is toxic to different organs. It's an X-linked disease. So in males, you see the full spectrum of disease, and a certain number of these young men, normally in early childhood, will develop a cerebral leukodystrophy, which is rapidly progressive and fatal. They can develop adrenal insufficiency at any age, but probably commonly when they're younger. And the others, so this is about 30% of patients, this is about 50% of patients in childhood, and the others will go on to develop a chronic progressive spastic paraparesis. Women, some of them will develop that chronic progressive spastic paraparesis much later on in life, and they don't get the other disease. So there are two severe forms of disease here, the cerebral ALD and the adrenal insufficiency, that are potentially life-threatening in childhood and are treatable. So for cerebral ALD, the treatment is bone marrow transplant. So if you get these young boys early enough and you bone marrow transplant them, you can stop progression of that disease and save their lives. And for adrenal insufficiency, you want to diagnose it before they have a crisis and start them on steroid replacement. So in order to do that, we need a newborn screening paradigm. Because it's X-linked, we actually have some experience of how we screen these families, because if you found a male with adrenomyeloneuropathy, the spastic paraparesis, and you screen the rest of the family, you can find young boys who carry the gene, so they know what they need to do. And it involves both a pediatric neurologist and a pediatric endocrinologist. The neurologist, this is a Dutch protocol now, is seeing the child every 6 months up to 24 months. And after this, they don't stop seeing them. After this, they get an MRI every 6 months up until they're 18, and then an MRI every year from then on. And similarly, a pediatric endocrinologist is seeing them very regularly in order to do blood tests to determine if their adrenal axis is working. But we already know that this is about 30% in childhood will develop this, 50% will develop this, and if you get this, you're quite likely to get this. So there's about 50% of male babies who aren't going to develop either of the forms of disease which we're screening for, but will develop an untreatable disease later on in life, although they'll be well for the first 20, 30 years of their life. Here's a diagnostic testing, and the diagnostic testing of this consists of, it's this halfway here really, you get a clinical status, so you get a baby or a man presenting with adrenomyeloneuropathy, they're presenting with clinical signs, you do the biochemistry looking for these very long chain fatty acids in the blood, and if it's positive, you do genetic testing. And if you do that, you can actually look at all the variants you get in genetic testing. So if you do that, then you get about 70% of the patients who have a clearly pathogenic or likely pathogenic variant, and about 20% of them have VUSs, and then the rest are likely benign or benign. So these are the genetic databases made from diagnostic testing, which we would rely on for variant interpretation. We've been doing newborn screening now in the States for over 5 years, in Holland for a similar amount of time. And the genetic database you get from the newborn screening paradigm, which is very similar. It's not a clinical status, so it's not a clinically affected child, it's an unaffected newborn baby, but the first tier is to do biochemistry. They're actually only looking at men in Holland. The second tier is a bit more biochemistry, like in PKO to confirm it. And finally, you do ABCD1 gene sequencing. But if you look at the variants you get now, it's a very different picture. So these babies are being picked up with positive biochemistry. The biochemical test is positive, but all of a sudden, 60% of them have got VUSs, and the number with pathogenic or likely pathogenic has come down to a third. So suddenly you're identifying a completely different group of patients to the patients you were identifying here. So what does that mean practically? So this is an example of a family tree drawn by one of our patients. The program was this little boy here who was born in Minnesota in the United States, where they've been doing screening for a while now, and was detected on newborn screening with abnormal very long chain fatty acids, and they were found to have a mutation in this family that hadn't been reported elsewhere. So that started off X-linked disease screening of the rest of the family, and they found a number of other individuals in the States, his mother, his grandfather, there's a cousin over here, who had the same biochemical picture, abnormal very long chain fatty acids, the same genotype, and indeed they then extended the screening over to the UK. So here's our proband and his uncle, who've both been found to be positive, and actually this is a much bigger cohort now. There are people in other countries and throughout the States who've been found. They've all got the mutation, they've all got the biochemistry. Nobody in this country has ever had any of the clinical symptoms or signs of adrenal leukodystrophy. So this looks like actually it's a VUS, but there was no way of knowing that. So screening is not the same as diagnosis. It's a very different process, and it isn't only identifying patients who present clinically, and it's certainly not only identifying patients who will present clinically with the phenotype which you're looking for, which in some diseases is a very specific part of the disease and not the whole spectrum. There's already a problem when you use a biochemical test. In metabolic medicine, we're really lucky. We have biochemical tests. We don't have to rely on the genetics, but that's already proving problematic, and it's going to be even worse if you're relying on next generation sequencing as your primary test. And this is some work done by Michael Gelb in the States, looking at big genomic databases and working out that if you did, and let's just concentrate on this column, if you used a genetic test for the whole of the USA to identify these 5 different conditions, all of which are metabolic conditions, and one of which on here is Pompe disease, then you would, so let's look at Pompe disease, you would actually get about 5,000 out of 4 million births being identified. And that's between 30 and 40 times what we know the prevalence of this disease is clinically. What's interesting is that if you could then actually take the 10 most common VUSs, and you could say confidently by doing some kind of confirmatory biochemical testing that these are not going to be pathogenic, we can show that if we express this enzyme, it's normal. You bring that number right down. So you bring it down by 3-fold. So it's only about 10 times now what we're expecting. So you need to go back to the biochemistry again, and people are doing that for both the diseases I've talked about. So this is work in Pompe disease using fibroblasts to express the mutations, the VUSs, and try and see whether they actually have significant biochemical effects. And this is actually a new biomarker for adrenal leukodystrophy. So if you look at lysophosphatidylcholine, you seem to be much more accurate, perhaps, in determining what the phenotype is. And interestingly, that family I showed you, although their very long chain fatty acids are abnormal, their lysophosphatidylcholine falls just below the range that is seen in clinically affected patients. So maybe that'll be a way forward to actually improving our sensitivity. So what I'd say is that we're proposing MBS rightly for diseases which are treatable. And the temptation seems to be that I've diagnosed your baby, you will now treat it for me. But that treatment, the response to the treatment, the response to the test is difficult to interpret, even if they're biochemical, and the treatment is rarely definitive. So the number of things where we're saying we're going to give you gene therapy, or I'm going to do a procedure that's going to cure this condition, is extremely low. Most babies are going into some form of continuous observation or continuous treatment that we hope is going to change their outcome in the long term. So we need to know which babies are going to benefit from screening, and that's very difficult for any single screening test. The screening tests we're seeing are not a single test. They're one biochemical test, two biochemical tests, a genetic test. If you're really coming in with a genetic test first, you're still going to need those biochemical tests afterwards. And what I'd say is that all of these, for any individual disease, the newborn screening program is bespoke. It needs to be designed from the ground up, depending on what tests we have available for that disease and what the clinical features of that disease is. And I don't think the way forward is to come in with a single test and say, look, we can do this for everybody and make economies of scale. That isn't actually, at the end of the day, going to give the best results for the children. If we decide we want to screen something, we need to screen for it in the best possible way.